some people sent questions, and then I also have some questions that we kind of get a lot in clinic as well. So I'm going to try to go through some of the questions here a little bit, and there's no particular order. We'll try to get through them and try to close a little bit after one. Maybe we'll do 1:45, depending on time here. Um, Alana, since you were online and so great with that last session, I want to start with you really, because I think we haven't given even enough time actually. So this one's apropos for you, and I think the question is that from somebody who says my son has Huntington's and was denied disability, and they're asking, what do I do next? How do I get more assistance at home? What generally is the process that I need to do for getting a disability, and I keep getting denied. So what resources, where do I go?
Okay, so this is
Complicated.
a question I get asked a lot. Usually takes me about an hour to answer that with folks when they come into the clinic. So basically, if you are applying for disability or a family member is helping you to apply and you get denied, you want to be sure to appeal right away, because that means that if you originally applied in January, you got denied in July, and you appeal that and you get approved in December, that means you're going to get that Social Security disability all the way back to January. Otherwise, if you don't appeal it and you start a new one, you're only going to get that 6 months. And that can end up being a really large amount of money for people because disability can take more than 6 months to get approved. So you want to appeal. Um, as far as getting more home assistance, that is usually handled by if you do not want to pay for that out of pocket, if you qualify for Medicaid, you can get some home assistance that way. Otherwise, that's out of pocket for most people. There's some limited therapies in the home that can take place for a while. There are a lot of wonderful disability resource information on the HDSA website. Allison Bartlett is the lawyer. She has many different articles on that. You can also call the HDSA and talk with her, and she may be able to help you out with some ideas. Okay, now resources. That's kind of a general question. What resources do I need? Um,
If you have, we can also put some of those on, if you have some general ones, we can also put those online. Uh,
yeah,
we can add those onto the site and later on. I know that's a complicated question.
yeah.
Yeah, it takes a lot more time. Wow, that's a tough question, I think. Why don't I ask another question of folks? Nicole, I see you here online, and I think one of the questions that comes up a lot that we've had, I'm going to ask you this, is, when should I get a swallow evaluation, and how often should that occur?
I would get a swallowing evaluation as early as possible. There's a lot of variability in normal swallowing, and so it allows us to really assess where you are. But as I spoke about earlier, we can't always assume that the person with Huntington's is showing signs of swallowing difficulties or reporting them. So get it early on, and then probably about every 12 to 18 months, 18 to 24 months. But everyone has a different progression. So if you're noticing things in between, get another swallow study. Can help provide certain strategies, maybe smaller sips, or it might give you a certain head position or position recommendations. Or we can always try alternative textures and consistencies if needed. But by doing the swallow study, it allows us to really figure out what is helpful for you and not just a guessing game. So maybe smaller sips works for some people. Maybe, a head chin tuck down might work for others. Straw might be better for some versus cup. It's really individualized. So it's not a one size fits all, despite sometimes what you read online. And so that evaluation can be really helpful to get that look at how to best manage it at that point in time. And some strategies previously were helpful and then become no longer helpful, or something that didn't work before may now be helpful. So we can always adjust in that way.
Cool. Yeah. Good advice. Awesome. I know there's more there. I guess we're spoiled. We do have our own swallow suite, actually, our own philosophy suite at the site. So
Yes, I'm
we can do
very.
them on site for folks who come in. So, um,
I wish
it,
every place had it. It would make it so much easier.
yeah, yeah. Um, Kayla, this may be tough and you may have kind of gone over some of this, but the question submitted was kind of like both my brother and sister have the same CAG repeat, kind of similar to that. But my brother had onset of symptoms or chorea at the age of 40, and it seems so much worse than my older sister, who has only mood and cognitive issues. So kind of wondering about why, and why is it different?
Yeah.
I might be able to help with that too.
What was that?
I might be able to help with that too, but yeah.
Okay. Yeah. So it depends from person to person, but one thing that we do know about are some genetic modifiers. So there's kind of two categories of these modifiers that we think about. So there within the HTT gene, there are some modifications, and then there's also many other genes in our body that have been found to impact that interaction in our body, but we're still learning a lot about that. In terms of that HTT modifier, there's actually in that long line of repeats at the very end, 95% of people, they have a CAA instead of CAG, so we call it an interruption there. And so in cases where people don't have this interruption, it can cause earlier age of symptom onset. And so that could be the case if someone's sister seems to have an earlier onset or worse symptoms. And so that's something that we know about, but still learning a lot about that. And the other genes that modify HD, we don't really have testing for that, but something that we're trying to learn more about as well. And then feel free to chime in with anything else, Dr. McFarland.
No, I think that's really good. It's tough, and I think the one thing is, we are all kind of a combination of the genes we get from our mom and dad, and we all get kind of a varied mix of that. And then there are also environmental factors that may play a role. So even though we might have the same CAG, that mix, that overlap of motor, cognitive, and psychiatric symptoms can be different. So you do see some variability even within a family member. And it's difficult to explain. Okay. So yeah, that was a good explanation. I think I'm going to field this one. It's a tough one, but it says, my loved one doesn't want to seek care, but clearly has symptoms and needs care. And what can I get him to do to seek care or help? So this is tough. We know that every family, there's a 50% chance that, you passing on the gene. And so families often have more than one person affected. So sometimes there's one person who is the one who's getting the care, but there's a family member who doesn't, or even it just could be a new family who just, they need care. So number one, I think to tell folks is, as physicians, caregivers, we have to still respect autonomy. So your right to choose care. Okay. So if a patient doesn't want care, we can't force it. We can provide it. We can, in a way, and even the same with treatments, we can bring people to the water, but we can't force them to drink in that kind of analogy. But autonomy is a big issue. Now, the big question sometimes comes in is, does that person have, the capacity to make judgments? That's more of a medical issue. And then if there is like a mood or cognitive issue that is causing impairment for your loved one, and you're feeling like they're making bad decisions, and if you can, so this gets into more of a legal issue. So physicians can only decide about capacity, and then The legal issue is lawyers need to decide on competence. So forcing care on someone who has maybe they're incapacitated due to dementia is a difficult process, and to prove that in a court to force someone to need care, sometimes patients like this do get into trouble, and they end up either in our state, sometimes they get into agitation or unsafe behaviors. They may get Baker acted, and that may force the issue for them, and then they may present to an emergency room or a hospital, and that may force psychiatric care, for instance. And that could be a good thing, though it is pretty traumatic on many patients, in my experience and others. And I'm sure family members can comment on that too. But that can be some way. So if you feel like your loved one, or someone you care about is unsafe, and they need care, there may be something to consider. But you have to understand that there are criteria for making that judgment. And so, but someone who's unsafe, maybe someone who's thinking of hurting themselves or somebody else, like they're suicidal, they're getting to that point. You can call the police, you can call health caregivers, to try to help intervene, but that's really forcing somebody and taking their rights away. So, the only other way I would kind of suggest is to try to keep working with your loved one. So they still have autonomy, they're able to make judgments basically, even though they might not be perfect or good. We have people who they don't want to go to a facility because they need care, like an assisted living facility, and they end up living on the street. And no matter what you do to try to get them into that facility, they prefer to be on the street, and that's not a good thing. But they still have the ability to make that decision. So I think it's really a safety issue. Or when it gets to kind of that threshold where you can sort of force things, but in general, we have to respect that people's wishes and their autonomy. So the only thing I can really tell folks is to continue to be supportive, be open to them, be available, be encouraging, to get care. And if you find a window, take it. Contact us and we will help you get that person in, and we'll take that window. And maybe that will be the opportunity that we can kind of strike, and they'll see kind of what we have to offer. But there are those patients, sometimes they don't want help, and there's really not much we can do without forcing it. So I don't know if Lana, if you have any comments on that too, but it's a difficult situation.
Well, the social work profession is also about people having the right to make their own decisions. And, this isn't just about HD. All of us have made some decisions that we regret at some point. So that is part of how we learn, and that is part of our life experience. And I would just say people have the right to live their lives as long as they are not hurting others. Yeah.
Yeah. I'm gonna, just because Beth, you're still online, I'm gonna ask you I'm gonna just give you the opportunity to tell patients kind of what happens if someone fails a driver test. And can you, I kind of know my side, but I think people might want to know kind of what is the process, that happens. Where does it go from there? And then is it automatic, don't drive? And
Okay, so as we said, a lot of things are variable, but if we've reached a point where symptoms are such that driving is truly not safe, that's the discussion that we have, because we want to all think about, number one, our own safety, the safety of others, our liability, all of those things. If this person hasn't been reported to the state, because sometimes people have been pulled over, maybe questioned by the authorities, maybe they've been reported to the state and the state is trying to decide whether they can keep a license. If they haven't been reported, they can voluntarily choose to give up their license. So they can choose on their own accord to go down to the DMV turn in their license, get an ID instead, so that they can still get on planes, do all the things they need an ID for. In some cases, when the safety is severe, sometimes it needs to kind of go up the chain where a report does go into the state licensing agency, and the state licensing agency, they're the only ones that can actually decide on someone keeping a license or not. But whether it's us or the physician feeling like safety is definitely compromised, at that point the state licensing agency comes into play and may make the choice for you. So being armed with the knowledge of whether things are safe, whether there's modifications that can be made to continue driving as long as possible, kind of helps to avoid the process where you're in a bind and the state is telling you, nope, you're done, and maybe you don't feel you're at that point yet. So trying to take control of it, but it can escalate up to the level where the licensing agency does revoke the license if a recommendation has been made, and particularly if a person's not feeling like they want to follow that recommendation.
Yeah, that's good. That's a good answer. There are lots of choices patients do have, and I think your note comes to me, and then I think if someone is reported, and I think just so people know that physicians have to eventually make a decision to help the state as to should this patient drive or not. And sometimes we do have to make the difficult decision to report somebody, and it's really a matter of both, personal and public safety. So I don't love doing it. I'll just tell you that. We never do, because we don't want to take someone's freedom away, but sometimes it's necessary and important. So, all right.
And I think,
yeah,
studies have shown sometimes people quit sooner than they have to. So again,
yeah,
getting assessed and determining, is there still a window, is important.
yeah. That's great. That's great. Trying to think. This may be more of a legal issue too. Again, so this is one about my mom has progressive dementia from her HD and needs constant care. She's widowed, and her children have stepped in to provide care. I mean, what do we do? How do we get power of attorney or establish being her surrogate? Do you have any guides, or what do they?
Oh,
I know it's more legal, but do you have any guides on what?
that's a bit of a difficult one. It depends on how far a person's dementia has progressed. Unfortunately, my experience is that most people wait too long to get some of those legal matters in place. So I would really recommend that for the person who has HD, that they get those in place so that they can be clear about who can make what kind of decisions for them. It is going to be a hardship for the family if they have to go through that court process of getting someone determined that they are not able to make their own decisions, and getting a power of attorney at that point. That sometimes that is not possible. If you wait too long, you cannot get a financial power of attorney, is my understanding. Being a healthcare surrogate, that's a little bit easier, and that under Florida statutes, that automatically falls to certain people if the person with HD has not already said who they wanted to make their medical decision. So I would just say being proactive on that, advance directives, legal matters, it's going to be easier for you and your family if you have that in place sooner, while someone can still make those decisions. Yeah.
Yeah. Yeah. Difficult. Kayla, I think you may have answered this question already. They're just asking kind of, my husband has a family history of HD and their family planning, and they're asking, what are our options if we don't want to have a kid or a child with HD?
Yeah, I can touch on it again. So there's several ways. I mentioned about genetic testing in pregnancy or before pregnancy with pre-implantation genetic testing, and then prenatal genetic testing. There's also adoption. That's also a possibility for people. And then people can choose to have a natural pregnancy, and there is still a possibility, the 50-50, that they wouldn't have a child with HD. And so everyone has their own decision. There's no right or wrong way to do it. But
Yeah, thanks. All right. Someone asked about they're hearing about new drugs for Huntington's and accelerated access. And what's the difference between compassionate use, the right to try, and expanded access? So I'll take that one because we are active in clinical trials. So let me try to explain. So it is true that there are drugs that are under trial, and they're experimental medications, okay? And they're usually sponsored by a pharmaceutical company. Now, just to make people understand, those are experimental drugs. They are not approved by any regulatory agency like the FDA. So me as a physician, I can't prescribe those medications, okay? Now, it is true that the U.S. government has approved the right to try, or what's called compassionate use of a drug in the case of someone who may have a terminal illness. And, what are their choices, really? There are no other treatments, okay, that they can explore, okay, and they have a terminal illness. You do have a right to try for compassionate use. Now, that said, you can't just ask any pharmaceutical company, say, I want your drug, to give that. They may not have a program for that or the ability to give it. Okay, so it is a bit up to the company and whether that drug or intervention is actually available to be given. Okay, and you do generally need a physician, but some medications you can ask to get. So just to keep that aware. There is a little bit of a difference to what's called expanded access compared to what's called the right to try or compassionate use. So right to try, compassionate use, these are really not regulated. Okay. In other words, they're not really, there's no institutional board regulating that. It's just you saying, I want to try the drug. I have nothing else to try, and it's available, and I want to get it. Okay. So you're doing it kind of off label. All right. Not really regulated necessarily. Expanded access is for drugs that are in trials. Okay. So, for instance, we have a few of our trials. For instance, pridopidine is one good example. That's the Berlinia trial, or what was called Proof HD. So the drug is still an experimental drug. It is not approved by the FDA, although, excuse me, they are seeking FDA approval and also approval in Europe as well at the same time. This drug did not meet their primary endpoint, though it was really well tolerated. And for some people, they thought it actually worked. So in this particular case, expanded access, usually a company will offer their drug that's still not approved, okay, through regulatory burden, okay, to be available. So they'll make it available to patients. Generally, the drug is free of charge, but all the monitoring and the clinical part is not. Okay, that's up to you. Okay. So, and companies have different policies regarding expanded access. So, but it generally is regulated. So it does undergo what's called an institutional review board. So as a physician, if it's a drug that's still in experimental use, and I think it may be beneficial for you, and you want to try it, and there's a program, I can ask for the drug if they offer it. So the company doesn't have to. They have to have a program. So they can offer it, but I would still need to get I need to have federal approval, get what's called an IND, and to get IRB, which is our institutional review board approval, to follow some protocol to treat someone with that drug. But the drug would be free. I'm just going to warn patients that sometimes it takes months to get that approval process done. So it takes some time. It's all paperwork. And there are many physicians out there who don't want to do the paperwork because it's such a regulatory burden. So And the other half of it really is some physicians, myself sometimes included, really, it's a matter of safety. So experimental drugs that aren't approved means that they either didn't work or they may have had some safety issues. So um, and so there's kind of it's a sticky situation sometimes for us about, allowing somebody to take a drug like that. So some people feel uncomfortable with doing that. So, but I will say, the Prolinea does have an expanded access program for their drug, and that's one that the company's actually sponsoring, so to make it a little bit easier. It still takes a while to get the regulatory part taken care of, but expanded access is a little bit different than the right to try. But so just remember, these are drugs that are generally not approved for that purpose, or they may be something that you can try, but they may not promise a specific, benefit, or we can't really promise it's going to work, basically. Okay.
Dr. McFarland, you actually
Yes.
had a question in our personal chat, but from Trevor and Kim.
Yeah.
They wanted to know, do you have any tips for pain management other than ibuprofen and Tylenol?
Yeah. So pain is a big question, and so I can answer that really. Pain is a big question and a problem in Huntington's. It's not well recognized, I think. So, and I think as physicians, we need to do a better job at asking about it. But the movements, stiffness, or sometimes rigidity, or even what's called dystonic posturing can be painful. I'll have to look at your case specifically, but there are things we can probably discuss, maybe more medications for the chorea to control that. If it's posturing or rigidity, we can use muscle relaxants sometimes. And that might even include Botox, that's just injectable. So other things we can do. And sometimes we just need to use what are called neuropathic pain medications. Okay. And then ultimately, I think we sometimes end up turning to palliative care, and some patients do need to have stronger pain medications. Okay. So I'll talk with you guys separately, but there are options, but please talk to your docs about pain if you have it. Thanks. That's a good question. Lana, maybe you have experience with this as well. So one of the questions was, how do I decide when I should get hospice involved? And how do I choose the right company? That may be difficult, but
Yeah. Okay, so how do I get hospice involved? I would say if you have some ongoing kind of disease, whether it's Huntington's disease or something else, and it is making things difficult and your pain is not controlled, I would at least start out with asking for an assessment from a hospice agency that provides palliative services. There's a lot of other benefits that come along with that, not only for symptoms like pain, agitation, anxiety, which can be very difficult for people as their life is changing. So I would say start out with that, and there's some other things that palliative care can also help with. Talking about what your wishes are going to be, getting paperwork in place, having discussions with the family so that everyone's aware of what is going on. So usually when people are going into hospice, my impression has been sorry, I lost my word right there. What I find is that people wait too late to go into hospice. I've worked in hospice for quite some time. My experience is that people wait until the very last few days before someone passes. Hospice can be a great support to people, and it can be 6 months is what they are looking at. That if a person has a disease that follows it, what is normally how it ends, if they're within that 6 months, they can have a lot more support from all the different team members on the hospice. So there's chaplains, there's social workers, there's nurses, there's a case manager, there's a doctor, there's grief support. So all of that can help people come to a better, let's say, maybe it not being quite so difficult having had that support from the team. So you can do an assessment with hospice. They can give you an idea if they do feel like a person may pass within 6 months or less, and then you can get signed up with that. That is paid for by Medicare and Medicaid. Most hospices also will provide hospice services if someone is not insured. So that's a good thing to know. Now, as far as like choosing a hospice that might be right for you, there's a couple different things to think about there. One main thing that I think is important is if they have an inpatient unit or not. An inpatient unit can be helpful because it can provide a respite stay of 5 nights. So say something has happened, there's another family member who is ill and you are the only one who can take care of them. A person can be in the respite and be taken care of there at the inpatient unit. And then when you come back home, you can have your person back home with you. The other thing is that there are times where people get towards the end of their life and they can no longer take oral medications. They're not effective for them because of extreme pain, agitation, anxiety. And they cannot leave those medications in the home. There are some medications that can only be given in inpatient unit. So for people who are under very difficult circumstances at the end of their life, I feel an inpatient unit can be very helpful. And a lot about picking out a hospice is how you feel about the team when they come out to see you and interview you and talk with you. Do they feel like they're on the same page with you? So that was a long answer, but yeah, there's a lot to think about there.
Yeah, it's tough, and I would. So I think sometimes bringing up the conversation in clinic, it's okay to do that and just ask. I think we are happy to help you kind of think about kind of the when question as well is sometimes difficult. And then there's sometimes a transition program where a nurse can come check from hospice intermittently, and you may not be early on, may not be in the process of dying, but they can follow you and provide additional assistance sometimes. So there are many programs like that. And most of the time I can still be, as a physician, can still remain your neurologist, but depending on insurance, sometimes the hospice may ask to be the primary person managing all the medications. And there's sometimes a give and take that we have to have, but we try to stay involved. So just for FYI. We're running out of time, so I'm going to finish. There was one question I really saw that kind of worried me and I thought was a good question, and I will just end with that. And I see Sharon's still online, and maybe people can also weigh in here, but basically there are people I have seen some caregivers say, times I want to walk away. I want to be there I want to be there to be supportive, but it's so draining. I'm burnt out. I'm depressed. I feel guilty and, about wanting respite, and I need help. So, first of all, I think that's great that someone would feel good enough to say that to us, but I think it's really important to hear that. In some cases, I think caregivers need support for themselves, and they may need actually to seek out some psychotherapy or therapy or counseling and even treatment in some cases. Okay. So I always kind of encourage caregivers to that you need to take care of yourself if you're going to be there for your loved one. So I don't know if that was really a question for you, Alana, too, but just in terms of treatment side, we can help, or we can at least get you help. So burnout's it's a real thing. I don't know if anyone else wants to weigh in on that or not. But, so,
Mm.
okay.
It's such a big question. Such a
Yeah.
big question.
Okay.
I think not isolating yourself. I see that with a lot of caregivers when they have a partner with HD or a child with HD, is that they tend to slowly lose those connections with other people. And that means less and less support for you. So whatever you can do to keep your connections, to get respite when you can, whether that's through friends, family, paying someone to be a caregiver, just the doing this by yourself is very difficult. So whatever you can do to keep your circles large and supportive, I in definitely all the things that you said too, Dr. McFarland, about having someone to talk to. Major life change. I think those are times when we all need someone to talk to, whether it's a therapist or spiritual support or family, whatever. Just reach out, keep on reaching out.